but sometimes if you remove the fracture entirely, you will get into the pulp. So ribbon can also be used to bridge fractures as well. And I'll go through the final restorative options, and I'll go through additional resources at the end. And again, biomimetic dentistry means mimicking life, lifelike. And another advantage of performing biomimetic restorations is that by doing partial coverage, you usually can keep restorations supergingival, which is an advantage to keeping a healthy periodontium. So that's another thing to consider. That's Sardinia, where I've studied. And that's Dave Allman and Dr. Della Perry. And I was there this past May, and one certificate is in English, one's in Italian.
Who's the gentleman on the right?
That's Dave Allman. He practices in Utah, and he's considered now the father of biomimetic dentistry. Question?
He's gone to the American Dental Association.
Yes.
Try to have certain codes.
Correct.
So I met him.
Right.
That's great.
They're working on that again, actually. They submitted revised codes, and they're hoping that they get it through, so insurance companies will cover this procedure. What do you think about that?
I'm having the same problem with arch formulation therapy. So I'm using aligners as periodontal aligners, not orthodontic aligners. So I was showing things that were revolutionary as he was. So what they did was at the American Dental Association, they now want all studies to have certain numbers of publications to be peer reviewed.
Right.
But if you show peer reviewed things, such as orthodontic research, which shows that orthodontic treatment doesn't have long-term success, you're not allowed to show that should we reevaluate codes that already be getting paid for, so people can have some understanding, versus doing treatments properly to have long-term results. So what they've done is they've needed another layer, a higher hoop to jump over.
Right.
So the two words that I'd like to wish is good luck.
Yeah.
It's protectionism, that's all it is.
Yeah, it is, and a lot of dentists who are insurance-based have an issue with doing biomimetic restorations because insurance companies will not reimburse properly for these procedures, and economically you have to spend a lot more time doing the procedures than you would with a conventional composite. That's Sardinia as well. So this is an interesting video I'm going to show you, the cycle of tooth death. Has anybody heard of Pascal Magne? No? He teaches at USC. He's really into biomimetic dentistry. He is from Geneva originally, and he's written a great book on anterior porcelain restorations. And he's into a very minimalistic dental approach. So this video is the cycle of tooth death, and hopefully it will work. Here it is. And it's just illustrating how our procedures can cause destruction. So here we're just showing an interproximal cavity on a premolar, and traditionally what we would do is perform an amalgam restoration with undercuts, which undermine the buccal and palatal cusps in this case. And the metal is rigid. It doesn't have the same modulus of elasticity as the surrounding tooth structure, and you end up, I'm sure you've all seen it, a cracked buccal wall or palatal wall of the tooth. So then you do a crown, but the remaining wall that you prepare for the crown is very thin. So and then that may crack off, so you end up doing a rigid post and core and a new crown. And then what happens potentially, I've seen it in my practice, that you get a vertical fracture or a tangential fracture of the root because of the rigidity of the material and not being compatible with the occlusal forces. And then you end up having to extract the tooth and do an implant. And implants don't always work. So, the patient could be stuck. And the moral of the story is it all started with a little interproximal cavity. So If you are more conservative, you can always repair a restoration, but you can't always, once the tooth is gone, it's gone. So I thought that was a powerful thing to show you. Oops. Okay. So, to continue, the benefits of biomimetic dentistry, as I've summarized, we conserve more pulps, we remove pathology, we try to leave as much tooth structure as possible. It actually strengthens the remaining tooth structure, and it stops the retreatment cycle, which is what was referred to in that video we just saw, and we can repair fractured teeth. And by stopping the retreatment cycle, as I was saying, we were taught in dental school, I'm sure we all went to Penn, most of us, some of us went to Penn. We were taught that you want to be definitive and you want to be perfect in terms of the restoration. But not that I don't want to be imperfect in my restorations, but the new paradigm is you can actually, if a restoration fails, if it's not a catastrophic failure, you can repair it or replace it and you still have the tooth. But if you have a catastrophic failure, which I'll show you, by doing a crown on a tooth, similar to what was done in that video, then you've lost a tooth. So in my own mouth, I would rather have a restoration that is repairable, like with a fail-safe mechanism, and you still have a tooth. Because I would want to avoid an implant if at possible. And teeth that have had endo are more likely to fracture catastrophically. So here's an example of that. Here's a crown. There's a fraction line on the interproximal. And I don't know how many of you have seen this when you've had crowns in patients' mouths that have come out, and they say, "Doc, the crown came out," they have it in their hand, but most of the tooth is within the crown. And it happened to me today. I actually had a patient come in, she had a gold inlay in her tooth, actually, but this was different. She had not been in for years, and she refused x-rays, and the tooth was a gum line and an endo, so in this case, the best treatment is an implant. But
that's mine.
Say, yeah, that's what you want. Yeah, I know. Question.
You're saying the best when you buy them at why, if it was within a millimeter of the gum line and you had a cast restoration, why have to do an canal?
You could try it. You could try it. You could also, with biomimetic dentistry, the way I've been taught, you can, and I've done it on teeth, you have a tooth that's a millimeter above the gum line that, well, in this case it was endodontically treated, but I've had cases where it's broken off a millimeter or two above the gum line where the pulp is really receded, and able to build the tooth back up with composite without doing the root canal. You can always do the root canal, but if you do the root canal and you put in a cast post, which is rigid, the tooth may fracture even more catastrophically in the future, and then you can't restore it. So,
just
what
for
I
my
do now
files.
is more conservative by having avoided it. At least I can
Okay,
try
thank you.
again. That's just my prejudice. For me, I'd rather try to hold on to the tooth as long as possible. And anyway, so this is what happened. The tooth structure was broken off inside the crown, and then you're faced with the choice of crown lengthening to try to do another crown, which may or may not work, or extraction and an implant. Whereas if you,
One set?
I don't know what this situation. This is not my slide. This is not the
Thank you.
slide. But I've seen a lot of cases where dentists see patients and they have large MOD amalgams, and they say, "Oh, this filling is wearing out. You should just do a crown." But I really think that's wrong. I mean, I think that if you can, if the amalgam is wearing fine, and I don't believe in just removing amalgams without cause, but if you do have to remove an amalgam, I believe that you could do a partial coverage restoration and not do a crown, and you have more tooth structure left, and you're more likely to hold on to the tooth, because if it does fail, you can repair it. That's just my preference.
A lot of insurance-based practice, you see big amalgams.
It's true, but that's, it's actually long term. It might not be in the insurance company's best interest to do that because the tooth may be lost and then it may need an implant. Whereas if the insurance company's covered partial coverage restorations.
They don't pay.
Exactly. They pay for.
They're not gonna
I know.
have one now.
They really don't.
Yeah,
want to
they
take this with
I
they
know.
don't pay nearly as much for all that.
That's true. I know. But it may not be in the patient's best interest. According to the literature. Yeah.
But when
Sure.
patient is in that, you're not really sure, especially if they say they can't afford it, that price. And you just, it's been documented, it's okay to reduce some decay, you're not supposed to call it, and you use a flat diagonal cases.
Ask her if that's too long.
Sometimes it's just the right time. The patient doesn't want the insurance and you do that, you leave some decay, you don't want to close the problem.
I'll get to that.
Okay.
Yeah. That's one thing I'm going to be talking about. This is just an example. This is Dr. Elliman's slide as well, where you can see that he left that little ridge between the palatal cavity and the occlusal cavity, rather than making one large cavity, because by leaving that piece of tooth structure and using biomimetic bonding techniques, it actually, the tooth is stronger, according to the literature. So by reducing stresses in biomimetic dentistry, within the composite, we increase the bond strength. By increasing the bond strength, we maintain the peripheral seal, and by maintaining the seal, it prevents reinfection and fracture. So through biomimetic techniques, which I'll show you, this is an introductory lecture, so I can't go through everything, but I will give you the basic concepts. By using biomimetic techniques, you maintain a better peripheral seal and are less likely to get reinfection of bacteria inside, between the margin of the restoration and the tooth, and you're less likely to get catastrophic failure. And I'll show you some examples of that. And here's a quote by Ray Bertolotti again, which I think is worth noting. When we consider that tooth reduction correlates with the need for subsequent endodontic treatment, the preferred treatment option often is one that relies on minimal tooth reduction. Adhesion with less need for tooth reduction is a highly desirable shift away from the tooth preparation for mechanical retention, which is what we were all taught in dental school. Maximum tooth conservation is a compelling advantage in using these materials and methods, and that was in 2007 in dental clinics of North America. And here's a crown prep, and when you do a crown prep, let's say on an upper molar, you need a certain amount of reduction for the material, and interproximally, you can get very close to the pulp if you remove 2.5 millimeters with a full shoulder, and the pulp can die, and then you're off on that cycle of death paradigm which I showed you before. This is a quote by a Japanese group of researchers. Novel resin bonding systems have the tensile and cohesive strength of the DEJ region. Accordingly, these materials have sufficient bonding performance, therefore new principles for restoration should be established. And this was in 2000. So because we have better bonding systems today, we can have more success with restorations that are more conservative. We rely more on adhesion rather than on mechanical retentive principles that we were taught in dental school. And the adhesive equation, this is a European group of researchers. Adhesive dentistry could be expressed as a simple relationship between bonds and stress. If the bonds can withstand the stresses, the restorative technique will be successful, at least for a relatively long period of time. It's my dad and myself playing golf. And that's another picture of Jerusalem. So here are 8 techniques to increase bond strength. You want an ideal caries removal endpoint, which I'll go into. We were discussing about caries, and a peripheral seal zone. You want to deactivate the MFPs, which I mentioned before. Use air abrasion to increase the surface area and get a better strength of the bond to the dent.